Lipoprotein metabolism disorders, clinical approach to LDL, HDL, VLDL, and IDL dyslipidemia. Dyslipidemia affecting LDL, HDL, VLDL, and IDL accounts for greater than 38% of global atherosclerotic cardiovascular disease, ASCVD, mortality. Pathogenic alterations in apolipoprotein B100 synthesis, LDL receptor activity, and hepatic lipase drive abnormal plasma lipoprotein profiles. Diagnosis hinges on a fasting lipid panel, calculated non-HDL C, and, when triglycerides exceed 400 mg per deciliter, direct LDL measurement or ultracentrifugation. First-line therapy is high-intensity statin, atorvastatin 40 to 80 mg PO daily, with guideline-directed LDL C targets, supplemented by ezetimibe or PCSK9 inhibitors for residual risk. Key points. Note, LDL C greater than or equal to 190 mg per deciliter defines very high-risk ASCVD and mandates high-intensity statin therapy, atorvastatin 40 to 80 mg PO daily, per ACC/AHA 2018 guideline. A 1 mg/dl reduction in LDL C lowers major ASCVD events by 0.5% per year, CTTC meta-analysis, 2019. High-intensity statins achieve a mean LDL C reduction of 50%, e.g., rosuvastatin 20 to 40 mg PO daily, within 4 weeks. Ezetimibe 10 mg PO daily added to statin therapy yields an additional 1520% LDL C reduction, IMPROVE-IT, 2015. PCSK9 inhibitors, alirocumab 75 mg SC Q2 weeks or evolocumab 140 mg SC monthly, lower LDL C by 5560% and reduce 5-year MACE by 15%. Fourier, Odyssey outcomes. HDL C less than 40 mg per deciliter in men and less than 50 mg per deciliter in women confers a 2030% increased risk of ASCVD independent of LDL C, ERIC cohort, 2020. Fibrates, fenofibrate 145 mg PO daily, reduce triglycerides by 4550% and VLDL ApoB by 30%, but confer a 0.5% absolute ASCVD risk reduction only in patients with TG greater than 500 mg per deciliter, Accord Lipid, 2010. Lifestyle modification targeting less than or equal to 130 mg per deciliter LDL C, greater than or equal to 150 minutes per week moderate intensity aerobic activity, and less than or equal to 7% body weight loss improves LDL C by 1015%, AHA/ACC 2022. Statin-associated myopathy incidence is 0.1% at high doses. Rhabdomyolysis occurs in 0.01%, Fayers data 2021. In patients with chronic kidney disease stage 3, eGFR 3059 ml/min/1.73 square meter, rosuvastatin dose should be limited to 20 mg daily, DIGO 2021. Overview and epidemiology. Lipoprotein metabolism disorders encompass quantitative and qualitative abnormalities of low-density lipoprotein, LDL, high-density lipoprotein, HDL, very low-density lipoprotein, VLDL, and intermediate-density lipoprotein, IDL. The International Classification of Diseases, 10th revision, ICD-10, codes include E78.0, pure hypercholesterolemia, E78.1, pure hypertriglyceridemia, E78.2, mixed hyperlipidemia, and E78.5, hyperlipidemia, unspecified. Globally, an estimated 1.9 billion adults, is almost equal to 26% of the world population, have elevated LDL C greater than or equal to 130 mg per deciliter, WHO Global Health Estimates, 2021. In the United States, 38.5% of adults greater than or equal to 20 years have dyslipidemia, with prevalence rising to 48.2% in those greater than or equal to 65 years, NANS 2020. Regionally, East Asian cohorts report lower mean LDL C, is almost equal to 110 mg per deciliter, but higher triglycerides, is almost equal to 150 mg per deciliter. Compared with North American cohorts, LDL C is almost equal to 130 mg per deciliter. TG is almost equal to 100 mg per deciliter. Key points: diet high in saturated fat, greater than 10% of total calories, relative risk, RR, 1.45, meta-analysis, 2020. Physical inactivity, less than 150 minutes per week, RR 1.30. Smoking, current, RR 2.00. Obesity, BMI greater than or equal to 30 kilograms per square meter, RR 1.55. Pathophysiology. Lipoprotein particles are spherical complexes of apolipoproteins, phospholipids, cholesterol esters, and triglycerides. LDL particles, primarily composed of a single ApoB100 molecule, deliver cholesterol to peripheral tissues via the LDL receptor, LDLR, mediated endocytosis. VLDL particles, assembled in hepatocytes with ApoB100 and triglycerides, are secreted into the circulation and hydrolyzed by lipoprotein lipase, LPL, to form IDL and subsequently LDL. HDL particles, containing ApoAI and ApoA2, mediate reverse cholesterol transport, RCT, through ATP-binding cassette transporters ABCA1 and ABCG1, delivering cholesterol to the liver for excretion via the bile. Genetic determinants, key points: LDLR mutations, is almost equal to 85% of heterozygous familial hypercholesterolemia, reduce LDL clearance, raising LDL C by 200300 mg/dl. PCSK9 gain-of-function variants increase LDLR degradation, elevating LDL C by 3050%. APOB missense mutations impair LDLR binding, causing LDL C elevations of 150250 mg/dl. ApoE4 allele carriers have higher IDL and VLDL remnants, increasing ASCVD risk by 1520%. Clinical presentation. Dyslipidemia is typically asymptomatic, however, certain phenotypes manifest with characteristic signs. In elderly patients, greater than 75Y, and those with type 2 diabetes, dyslipidemia may present as silent ASCVD with atypical chest discomfort. The prevalence of silent myocardial ischemia in diabetics is 22%, DIAD trial. Key points: tendon xanthomas, present in is almost equal to 20% of heterozygous FH, specificity greater than 95% for LDL C greater than or equal to 190 mg per deciliter. Corneal arcus, prevalence is almost equal to 30% in adults greater than 50Y with LDL C greater than 160 mg per deciliter. Eruptive xanthomas, seen in is almost equal to 5% of severe hypertriglyceridemia, TG greater than 1000 mg per deciliter. Absent peripheral pulses in advanced atherosclerosis, sensitivity is almost equal to 70%, specificity is almost equal to 85% for greater than or equal to 70% coronary artery stenosis. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. 1. Fasting lipid panel, greater than or equal to 8H fast key points, total cholesterol, TC, less than 200 mg per deciliter, optimal. LDL C calculated by Friedewald formula if TG less than or equal to 400 mg per deciliter, otherwise, direct LDL C assay. HDL C greater than or equal to 40 mg per deciliter, men, / greater than or equal to 50 mg per deciliter, women. Triglycerides, TG, less than 150 mg per deciliter, optimal. References. 1. Feingold K.R. et al. Introduction to Lipids and Lipoproteins. 2000, PMID, 2624789, https://pubmed.ncbi.nlm.nih.gov/2624789. 2. MedMind AI et al. Apolipoproteins in Vascular Biology and Atherosclerotic Disease. Nature Reviews. Cardiology. 2022, 19, 3168-179. PMID, 3462571, https://pubmed.ncbi.nlm.nih.gov/3462571. DOI 10.1038/S41569-021000613-5. 3. McCullough et al. The effect of carbohydrate restriction on lipids, lipoproteins, and nuclear magnetic resonance-based metabolites. Caliber, a randomized parallel trial. Nutrients. 2023, 15-13. PMID 3744738, https://pubmed.ncbi.nlm.nih.gov/3744738. DOI 10.3390/new151330002. 4. Ramirez-Cisneros et al. Apolipoprotein CII correlates with lipoproteins in the fed state and is not regulated by leptin administration in states of hypoleptinemia induced by acute or chronic energy deficiency. Results from 2 randomized controlled trials. Diabetes, Obesity and Metabolism. 2025, 27, 4/2012-2023. PMID 398100632, https://pubmed.ncbi.nlm.nih.gov/398100632. DOI 10.1111/DOM16194. 5. Heidman et al. Composition and distribution of lipoproteins after evolocumab in familial dyslipidemia, a randomized controlled trial. Journal of Clinical Lipidology. 2023, 17, 5666-676. PMID 375179114, https://pubmed.ncbi.nlm.nih.gov/375179114. DOI 10.1016/J.JCL.2023.07.004. 6. Yamashita et al. Distinct differences in lipoprotein particle number evaluation between GPHPLC and NMR. Analysis in dyslipidemic patients administered a selective PAR modulator, pemafibrate. Journal of Atherosclerosis and Thrombosis. 2021, 28, 9974-996. PMID 3353638, https://pubmed.ncbi.nlm.nih.gov/3353638. DOI 10.5551/J.60764. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.